Hello?
We can hear you clearly.
Yeah, to hear you.
Okay, thank you. We had a problem with the video volume, so I had to make sure. So good evening, everyone. Thank you so much for your time. My name is Maxina Munkombwe, as Atupele has already said, and my presentation is on cardiac CT angiography. So go right ahead since the moderator is not yet here. I'll just take us through a bit through the outline of my presentation. I'll first look at the overview, a bit of the anatomy, and then we'll look at the indications and the contraindications, how to prepare the patient for this examination in the room itself, and then we look at the procedure. At the end, we'll look a bit about limitations, and then we'll see a few cases about the examination. So what is CTA? What is cardiac CTA? So generally, this is an X-ray examination that involves invasive, that is non-invasive and involves contrast. So how can you define it in, if you are just looking at it from a general aspect? Really, it's just like CT, the same CT that we do, but then now you're going to look at the coronary arteries themselves, and you want to inject contrast in these coronary arteries. But then this examination is very challenging. Why? It's challenging because the heart is a moving organ. And as we know in radiography, motion is one of the major causes of artifacts. So this becomes a challenge that you have to overcome when doing this examination. So CCTA provides a good visualization of coronary arteries, and we all know that coronary arteries, they provide oxygenated blood to the heart. So any disruption to any of them will cause an impaired oxygen supply to the heart, which may cause ischemia. So what information can we get from a cardiac CCTA? Why do it anyway? So the first thing that we can get from a cardiac CCTA is the calcium score, which is basically the amount of calcium that may be present in one or all of the arteries, the coronary arteries, and as well as the ascending aorta. So this helps us to rule out atherosclerosis. For CCTA, we can also assess the coronary arteries themselves. We check the lumen, they help us evaluate the lumen of the coronary arteries, check for stenosis, any blockages. If they are previously put stents or any grafts, then you can actually check them and make sure if they are patent or not. So you can, apart from this, cardiac function can also be assessed with this same examination, where you will check the different wall thicknesses at different levels. We're going to see this as we go down. So as you do this, you may have incidental findings like cardiac masses, pericardial effusion. You may also actually pick out valvular pathologies as you are doing this examination. I must mention, however, that CCTA is not the gold standard right now with the current literature. It's not the gold standard to evaluate coronary arteries. The invasive coronary angiography, or if you would like to say cardiac catheterization, it still remains the gold standard in the assessment of coronary arteries. But we know that CT scans are more available. And then also because CCTA that is not invasive, it does not involve catheterization, CCTA now becomes a better alternative for patients who cannot tolerate catheterization. Other modalities that can assess coronary arteries is nuclear medicine, which can use technetium. Hello? Which can use.
We can hear you. Go ahead.
Okay. Nuclear medicine, which uses technetium-99, cystatin, there's MRI, there's also echo, otherwise known as the cardiac ultrasound. So image quality is one of the most important things when you're doing this examination. So we're going to look at just a little bit about contrast, temporal, and spatial resolution, just to see how you can maximize and how you can make sure that you get an optimal diagnostic image. So understanding the basic concepts of temporal contrast as well as spatial resolution in CCT is very necessary because they affect the image quality directly. So I put in a table that just gives an overview on the spatial resolution, contrast resolution, and temporal resolution. So I'm more interested in the CT because that's our primary topic today. You can see how high the temporal resolution of CT is. And then you can see that for contrast resolution is very low. Actually, it's written low to moderate. And then the spatial resolution, you see that is at 0.5 to 0.6 as compared to the other ones where MRI, you see 1 to 2, PET is giving us 4 to 10, SPECT is giving us about 4 to 15. But that was just an overview just for us to look at how the differences in these factors that affect image quality are. So spatial resolution of CT is very excellent, as we've seen in the other table. And that is one of the reasons that CT is excellent for visual for assessment of coronary arteries. However, the contrast resolution is not intrinsically high. So on its own, CT on its own, it doesn't have, it cannot differentiate properly between soft tissue on its own unless you inject something else, which is contrast media now, that you have to inject for you to differentiate between tissues. Otherwise, for you to differentiate between small changes, it becomes very difficult. But then even just with administering contrast, there are certain factors that you can still put in to make sure that you even get a better image. So you need proper timing. Also, the injection rate is a big factor, and the volume of contrast that you inject in the patient, as well as the tube voltage itself. So a few articles do talk about reducing the kV to 100 or 80 kV, but I must mention that at the station where I'm at, we do not manipulate this kV, but it's out there in the literature for those who would want to read more about it. The temporal resolution is vital during cardiac CT because it's one of the things that gets affected primarily when there's motion, and we know that the heart is a moving object. So temporal resolution becomes very vital in this sense. So it's one of the things that you have to think about. How am I going to make sure that my temporal resolution is increased or it becomes better? Another point that I would like to bring across, just as an overview, which CT scans can you use for cardiac CT angiography? Is it any CT scan that you have? So you find that only 16 slides and above can support this examination. However, as you go higher, you get more functions, you get better diagnostic quality, you also get better scanning speeds. As you know, we're trying to reduce motion artifacts. So the higher you go, really, you get a better diagnostic image. So let's look a bit at the heart anatomy. Specifically, I want to look at the coronary arteries because that's what we're concerned about tonight. So the coronary arteries, they branch from the ascending aorta. On our right side, primarily you've got the right coronary artery, and on the left side, you've got the left main coronary artery. which branches into the left circumflex artery and the left anterior descending artery. The right coronary artery will also branch into two. It will branch into the right acute marginal artery and the posterior descending artery, which you are going to see here. There are even other smaller branches, like the left anterior descending aorta has two diagonal arteries. And then there's also the marginal arteries in the left circumflex artery. So these small vessels are very important to know, because when you're going to start scanning now, you need to know which vessel is branching from which. If there's a problem in one vessel, you need to be aware that this problem is in which artery, so that you don't mislabel the pathology. Another thing that is important to note is which part of the heart do each of these coronary arteries supply. So the right coronary artery will supply the right atrium and the right ventricle. The right marginal artery will supply the right ventricle and the apex. The left marginal artery will supply the left ventricle. The LAD will supply the right ventricle, left ventricle, and the IVS. This is just a map to show how the arteries are coming down from the ascending aorta. So it just gives you a proper idea. So remember, on the left side, you've got the left main coronary artery branching into the left circumflex and the left anterior descending aorta. Then there are smaller branches that you may see. On the LAD, you've got the D1 or D2 rather, or the diagonal artery. On the left circumflex, you may have the marginal artery in the 1 or 2 or 3, depending on the patient. On the right side, the right coronary artery, mainly you have the right acute marginal artery that you see right here in the middle, in the PDA. But you may see also these small branches, and you need to be aware of these branches and where they're supposed to branch from. So what indications or what reasons would a doctor send a patient for CCTA? Suspected coronary arterial disease mostly is the reason that the doctor will send the patient to come to your department. But there are other indications like atypical chest pain, which is also fairly common. Coronary artery anomaly, the descent is not so common, but this type of patients can also be sent. Assessment of stents, existing grafts, the demonstration of developmental anomalies of coronary arteries are one of the indications. Then what are the contraindications for the examination? So as we know, for all contrast media examinations, there are contraindications that exist. So just like the other exams, for a pregnant person, normally would not want to go ahead and subject a patient to a CT, a cardiac CT angiography, unless otherwise. And then for patients that have allergies, especially to iodine, you may want to pre-medicate the patient before the examination, or at least for our center, that's what we do. We pre-medicate the patient, and then we book the examination for the following day. But this is not just done within the department. The moment we find out the patient is allergic, we call the referring doctor, and then we discuss with him. And if he says that he's going to cancel the examination, then well, we have to honor that. But most of the times we pre-medicate, and then the following day we go ahead and do the examination. However, specific to this exam is of most importance to note that an irregular heartbeat is one of the reasons that is one of the big contraindications, because as I said earlier when we started this presentation, you really face a big challenge of motion. First, the heart itself is a moving organ, and then there's the breathing that is involved. So you really want to reduce these two factors as much as you can. So reduction of motion and is one of the big factors that you have to think about at the back of your mind. Whatever you are doing, just think of at the back of your mind, how can I make sure that the motion is as low as possible without harming the patient? So conditions like atrial fibrillation also become a contraindication because it directly affects the temporal resolution. So when the patient comes to book the examination, you may also want to explain the procedure. You may tell them how to do breath holding and whatnot, but then sometimes they may have conditions where they can't hold their breath for 13 seconds, or maybe even less than 10 seconds, they can't hold their breath. So if it happens like that, again, you have to call the doctor and explain to him that this patient can't actually hold their breath. So this examination, even if we have to go ahead and do it, it will not be diagnostic. Morbid obesity as well is one of the contraindications mostly because of the diagnostic value is significantly reduced. The other two contraindications that I'll mention is severe coronary calcium, which directly affects spatial resolution, and hyperthyroidism. So though these are the ones I've mentioned, these are not the main ones, but I'll leave it open. Maybe another person has other contraindications that they may think of. So I'm open to allow for discussion at the end of this presentation. So when you are booking the patient, you need to now explain the procedure, the full procedure. I don't know why specifically, but patients who come for CCTA mostly come very scared. So you have to give the patient a full explanation and make sure that they understand every aspect of your instructions. And then you tell them, just like any other contrast media examination, that they shouldn't take any food 4 to 6 hours before the examination. They must just drink enough water and hydrate their bodies. But don't just end on giving a full explanation to the patient. You have to also now communicate with the doctor and the nurse. For example, if a patient is in the ward, which is most of the times, though we do have walk-in patients as well, you may want to also tell the nurse and emphasize that the patient should not eat anything 4 to 6 hours before the examination. You also tell the patient that you also tell the nurse that the patient shouldn't take any caffeinated foods 12 hours before the examination. Also communicate to the doctor, specifically ask about the heart rate of the patient and the medication that the patient is taking. You have to, so sometimes the heart rate is already steady, but you still have to tell them about the fact that there may be a possibility that they may need to administer beta blockers. For other doctors, though, they prefer to just give beta blockers anyway, anyway, because they know that there's that likelihood that the heart rate may go up. And then you also want to find out about the urea and creatinine. Make sure that blood was taken and the urea and the creatinine is normal, and that you actually get a copy of that and you put it in the file also. So just hearing that it's normal is not enough. You have to put this and make sure that it's in the file. And then the other thing that you have to make sure that is prepared is the injector, contrast media factors. So you prepare your injector, you need to decide on your injection rate. Remember, the patient already came to your department. So you weigh them and you know how much they weigh. You must decide now how much you must go, how much injection rate you're going to give based on that. Make sure that your injector is working well. And then on the contrast itself, for CCTA, you may not use contrast at less than 350 milligrams per mole in concentration, only 350 and above. So you need to make sure that the contrast you have has a concentration of 350 milligrams per mole and above. So For our site, we use Omipay, but out of this, maybe there are other ones that may be available, but these are the ones that I know about. And then the other thing that is important to note under this is for shorter scan times, remember we're just looking at the heart itself. It's a smaller structure than we would normally image. So there will be a shorter scan time than normal. So this is why if you see the injection rate is at 4 mils per second. I think I put it somewhere. Yeah, it's usually at 4 mils per second. And then for larger patients, you also want to increase your injection rate in order to still try and maintain your a good image quality. So in weight and injection rates are very much connected. For smaller patients, the injection rate, you can even go as low as 3.5. And for bigger patients, you have to go 5.5 maybe. But normally for an average adult, we just usually give around 4 mils per second for someone who weighs between 60 and 100. And most people, they do fall around this. Most people that come for the examination, they fall around this range. Then how do you now inject the contrast? Is it the same as any other examination? So there's actually two ways of injecting contrast when you're doing this examination. You may first want to go with contrast at 4 mils per second, then you flash out with normal saline, also at 4 mils per second. This is what most of the departments actually do. However, there's another way, which is biphasic, where you're going to inject with contrast first at 4 mils per second, and then the second phase, you inject contrast and normal saline in equal volumes. And then, so here, how do you achieve this? You need to use 2 injectors. I've not really seen this myself, but it's something that is there. And then it can be something that is interesting to read more about. Otherwise, for us, we just use the single phase where we inject contrast, and then we follow through with normal saline and we flash out. The other thing that you have to make sure that are ready is your room itself. Do you have your BP machine, your ECG? Do you have gel for electrodes? And one of the most important things, your IV line. The most preferable, the IV line that is most preferable is the 18G, which is the green cannula. So as much as you can, try and use the green cannula because it's big and it allows you also to inject contrast at a higher injection rate as compared to the green cannula. But you may face certain patients that maybe you fail to put a green cannula, and if they are small enough, you may still go with the green cannula because you can still go and use 3.5 mils per second as your injection rate. And when the patient now actually comes to the department on the actual day, make sure that the patient is very calm. This is very important. When the patient is calm, the examination moves so smoothly and the heart rate is steady. There's no, there's just a smooth flow of events. So just make sure you talk to the patient. Again, explain the procedure to them that you explained when you're booking. Make sure you get your consent and place your cannula now on the right arm. Depending on your departmental protocol, this may be a nurse that will have to do this. But I know other departments, the radiographers are the ones that put the cannulas. And when you put it now, make sure now you put the patient on the bed and you place your ECG leads and make sure that you place them correctly. Ask the patient again to hold their breath and then observe the heart rate on your ECG monitor. So, and also observe how long they're able to hold their breath. So when asking them to breathe in and hold their breath, when you ask them to hold their breath, ask them to slightly breathe in and then now hold their breath and then see how long they're going to do that. So if they can do it for 13 seconds, that's even better. But sometimes they can only manage up to 10 seconds, which is also acceptable. But optimally, we prefer 13 seconds, at least 13 seconds. When you now position the patient, you need to position the patient in supine for you to get your AP scanogram. And then the positioning basically is the same as that of chest CT, but you make a few changes for this one because your heart is your main interest. You're going to offset the patient slightly to the right so that the heart is now at the center of the scan field. And then whether the patient goes in feet first or head first, it doesn't matter. It depends with your departmental protocol. Our patients go in feet first. And the most important thing, however, is just to make sure that the patient is in supine and that the patient is calm. The patient is centered to the patient is offset to the right so that the heart is centered in the scan field, and that the patient's arms are placed above the head. And then you also make sure that there are no ECG leads or tubes that are in the scan range, because you don't want cables that are interfering with your image after you get it. So just make sure that those things are out of the way. So for a lot of departments, they also administer sublingual nitrates, which really just helps you to dilate your coronary arteries for better visualization. And the last thing that you need to make sure now, confirm that each of the ECG electrodes are correctly put, in that there's a signal, a clean signal next to each of them. If that is confirmed, then you know that now you are done with positioning of the patient. So an image right here, just to help us understand what I'm trying to put across. Basically, you've got 4 electrodes for your ECG. You have 2 superior and 2 inferior. So the 2 superior should be each placed in both the right and left mid-clavicular planes, right underneath, right inferior to the scapula. So you see that on my left side, the electrodes are put slightly way below. You can see where the clavicle is way above, even on the other side, though it is worse on the left side. So that is not the correct way of putting it. Rather, like on my right side, it should be right below the clavicles, and inferiorly it should be subcostal, but in the same line as the axillary. And positioning of the patient, you can position the patient. This is what I was trying to say as well. Make sure that the patient is calm. Make sure the patient is offset to the right. However, on this patient, if you can see, the cables were not moved out. So these may show over the scan range. So you have to make sure that these cables are placed away. You can even pin them to the beddings or the bed sheet that is put on the table. But it's very important to just make sure that nothing is in the way of your scanning field. So we may now get right to it on how we do the actual procedure. And before we go right to the procedure, I want to mention 2 important things. We have 2 types of protocols when you are scanning for CCTA, which is prospective as well as retrospective. So prospective is also known as step and shoot, and the main difference really is it will only scan for one portion of the RR interval. It will not scan continuously. In this, it will only scan during diastole, pause during systole, continue during diastole, pause during systole, just like that. So basically, when you're scanning, you hear scanning sound, pause, scanning sound, scanning sound, pause, scanning sound, pause, just like that. And because of this, it provides a lower dose than the retrospective. And also because it only scans parts of the RR interval and does not cover the entire thing, functional analysis is not possible. Retrospective, on the other hand, it will scan through continuously throughout the RR interval. And because of this, multi-segmental reconstruction is available for retrospective, and functional analysis can also be obtained using the data. So this is what you have on your screen when you go on your cardiac protocols. This is what you have. So the caution score, prospective gating and retrospective gating. These are the ones that we these are the ones that are options when you want to scan for this. However, the other ones that you see down here and on my right, we don't use them ourselves. So I don't have much information concerning them. However, the first three are the ones that we usually get to use. But most, we only use the caution score as well as the retrospective gating because it gives us function. Most of the patients that the doctor will refer to our department, they are not only interested in the visualization of the coronary arteries, they also want to find out the function. They also want to find out the function of the heart. So how do you do your caution score now? So the first thing that you have to know is caution score also uses prospective ECG gating. Why is this important? This is important to know because it means that the scanning doesn't happen continuously. It only scans when the RR interval is in diastole. So it will scan, pause, scan, pause, scan, pause. So this also means that there's a lower dose for caution score. So why is this important? It means that it's actually possible if for certain patients that have a high risk to coronary artery disease, they may be screened for the level or presence of calcium in their coronary arteries. It can be used as a mode of screening. And then let's get to how we can do it now. So when you go on your screen, you have your calcium score there. You select it, and when you select it, just like any other CT examination, it will request you to do a topogram. So you get a topogram of the whole chest, AP and lateral scanograms, and then once you get your topogram, you can now plan for your calcium score. So your calcium score, you don't need to scan the whole chest again. This time, you just want to collimate right to the heart because you're interested in the amount of calcium in the coronary arteries and the ascending aorta. You position your scan to make sure that superiorly you go above the carina, and inferiorly you make sure you include the apex of the heart, but sometimes you may not really see it. So the general rule is that you go 2 centimeters below the diaphragm on the same side of the heart. For dextrocardiac patients, if the heart is on the right, then now you're using your diaphragm on the right. You go 2 centimeters below and make sure you reduce your field of view in order to increase the image quality. Because remember, for this examination, you really, really want to have a good image quality in order for you to be able to pick out if there's any pathology, and also to make sure that you do not miss out any pathology. So when you scan, this is what you usually get on the screen. You've got a 75% volume, and you've got all the images down here. So when you get them, you may quickly want to just check if you're fine, and then you quit and go to retrospective, because now the patient is already on the bed. Remember, you don't want to keep the patient more than is necessary, because the heart rate may start going up. So you just make sure that the volume is there, your actual volumes are there, and that they are fine. You quit, and now you go to your retrospective. So if your department or if a doctor specifically says prospective gating, then that's what you are going to choose. But as I said, for our center, we usually go for retrospective because they also want to see the function of the heart. You go right now to the retrospective. So you don't need to get another topogram, and you can just use the same images that you got from Kausha. So if you go to the volume there, it allows you, you can select your first image where you want your scan to start from. So if you see on my left where I put start there, there's you can see the ascending aorta, a little bit of the pulmonary artery and right by the case, and sort of a little bit of the descending aorta right there. So you pick your slice there. That's where your scan is going to start. And then you go pick your end slice. So you go right at the bottom. So it's always advisable to pick a few centimeters of the liver, because sometimes the breathing, the breath holding may not be very consistent. So if you go right where the heart is ending, you may end up, when you're doing the actual scan, that you cut off part of the heart. So you want to go a few centimeters with some liver tissue, just to make sure that if there's any inconsistency, still make sure that the whole heart is covered. And then the other thing that is important to note is the left anterior descending aorta. It's located superior to the origin of the left main coronary artery. So you need to be able to compensate for this so that you do not cut it off as well. When you are done with your selection of protocol, as I said, we're using the retrospective protocol here. You also come here on your table. The start position, if you see right in the middle of this table, is start position and end position. So using the volume that you got under caution score, row number 4, under start position there, you put a numerical number there, and on end position, you put a numerical number, making sure that, as I said, that the whole heart is covered. And you also give adjustments to make sure that if there's any inconsistencies with breathing, you do not cut off any part of the heart. And then the moment you select those things, now you can go ahead and do your scanning. But before it allows you to do the scan, automatically it takes you to another breath holding practice routine. So here you see something like this on the screen, where breathing exercise is in progress. Unfortunately, I couldn't get a graph for this, but basically it's just a graph that allows you to see how the heart rate is fluctuating. And then you monitor this. You ask the patient is asked to breathe in, and they're asked to hold their breath, and then you monitor the heart rate during their breath hold. So ensure that this patient is able to hold their breath for the required scan time, and you monitor the heart rate during this time. Approximately, the heart rate should just vary between 60 and 70. So if you get a patient who has, for example, 65 beats per minute, and you see your graph now, it should not fluctuate more than 10% from that 65. So it's 65 to 55. If a patient has 65 beats per minute, if it goes to 55, that's acceptable. If it goes to 75, that's acceptable. But if it goes beyond that, that you can't go ahead with the examination. So you need to go back in the room, you calm down the patient, talk to them, calm them down, you try again. You keep trying until when you see that, okay, if it's not helping, then you now have to call the referring doctor. You may ask them to administer some beta blockers. However, there are certain patients, because of certain pre-existing conditions, the doctor may say, for that patient, I can't administer beta blockers. I'll just cancel the examination and I'll refer them to another, they will refer them for another modality. However, sometimes when you just administer the beta blockers and you wait a bit, usually the heart rate does come down. But and also talking to the patient, making sure that the patient is calm even before you start calling the doctor, it also helps. So let's get right into the CCTA itself, the cardiac CT angiography. So when you start scanning for this, the first thing that you have to check now, you have to confirm, you have to acquire your S and V image. And for us, we put our ROI in the descending aorta. However, I've come across literature that has suggested left atrium and ascending aorta, but we have not tried this. We use our descending aorta and we set our trigger at 180 Hounsfield units. You can also actually do manual, where you put your ROI just way outside of your scan field, and then this way you're going to monitor the contrast manually. And now this one you have to be very careful because you may miss the contrast. So you have to be very attentive that the moment you see the contrast is in there, then you press your scan and then you do and then you are able to do your scan. So if everything is okay, the heart rate is steady, the patient is calm, you are satisfied with the way everything is going, then you can go ahead and do the scan. But before you do a scan, reassure the patient, warn them and tell them about the warm sensation that they may feel when the contrast is going in, because if you don't warn them, again, they may get scared, which may disturb the heart rate. So if your heart rate is stable, you warned your patient and everything else is okay, then you may go ahead. So contrast injection and scanning, they are started simultaneously, but there's a 5-second delay of scanning before the scan can start. And then you obtain your volumes. After you obtain your volumes, finally you can scan the whole chest now. And then the examination is done. But before the patient leaves the bed, you want to make sure that you have checked certain things. So there's a small checklist that you have to, there's a small checklist that you have to tick before you remove the patient from the bed. Now you go to your volumes and make sure that you start checking for this in motion. Check that the patient did not move. How would you know? So if the patient did not move, obviously there will be no blurring between structures. Check for full inspiration, check your ECG graph, check if there's proper calcium, if there's proper coronary artery visualization, make sure all your volumes are also there. So if you are checking for motion, for example, using this image, you can see the proper boundaries between the aorta, the right atrium. You can see these structures. There's proper boundaries between them. If there's motion, you would see blurring and you can't really appreciate these boundaries. So if everything is just distinct and properly, and you make sure you're satisfied with this, you can go to the next thing, which is visualization of the coronary arteries themselves. So here you're going to go through down the volume. I couldn't put a video, but you start from the superior aspect of the images to check if there's adequate visualization of the coronary arteries. Make sure that the contrast, proper contrast, there's proper contrast visualization in each of the arteries. And if you are satisfied, you can also now go and check for, you can go and check for other things like full inspiration. Remember, you also did a full scan of the chest. So this is just an example for calcium visualization, for coronary artery contrast media visualization. See the topmost images, and when you compare those with the ones below, you can see that the ones below, there's adequate visualization of the coronary arteries, and the one on top, the visualization is not optimal. You can't really even see distinctly where each artery is originating from, and it's very difficult to follow it. So like this one, this is one of the CT scans that would say has poor quality. And the one down below, if you get like that, then you know that you'll be able to properly assess your coronary arteries and be able to pick any pathologies if they are present. If you are satisfied with everything, now the patient can be removed from the table, and you give your post-examination control, your post-examination instructions. Remember, just any contrast media examination, the patient should be kept for maybe 5 minutes just to observe them and see if they react to the contrast media that you've just administered. But for this one, because the doctor may have also administered beta blockers, you may want to check the blood pressure. And once the nurse comes to get the patient, also advise them that periodically they can just check the blood pressure of the patient to make sure that it doesn't go too low. And other instructions that you may want to give the patient is also how to get their results and whatnot. And once you're done with that, you've checked that you have all your volumes, you have all the images that you have. Now you are ready to reconstruct your images. So reconstructing of your images is again, and you have calcium score, you have coronary arteries themselves, and then you have the function, the CFA, which is the function. And then you start with your calcium score now to start checking manually if there's any calcifications in the coronary artery. So if you see this image here, on my right, there's a list of the coronary arteries that are there. So not all of them are listed, but if you pick out any calcifications, you can just report them under other below here. So this image, I just put it here because this is basically where you may want to start from. And then as you go down, you start now picking out each of these coronary arteries. So when you pick out one, you click on it, it will give you a specific color. You go right here on your diagram, on your volume, and then you start following that artery, and you start manually picking now. For example, here on the left topmost, you see the RCA, the right coronary artery. It's giving you a color purple. So on my volume, I picked out a calcification and I clicked on it, it turned purple. Below that, I picked 2 other calcifications. I clicked on them, it turned purple. I continued following the vessel. Mid vessel, I picked another one, I clicked on it, it turned purple. You have to click till you reach the end. So sometimes you may think like, okay, I'll just end here. Make sure that the artery has gone all the way to the end and that you have not left any calcifications. When you are done, you save that and you go to the next one. So I also did an LED just as an example, the left anterior descending artery, which gives you the color blue. So I picked the calcification and clicked on it, gave me blue, clicked on it, it gave me blue just like that. And you go and do everything else. Now, the aorta is also one of the arteries that you're going to assess for calcification, but only the ascending aorta. Do not also include the descending aorta, only the ascending aorta. So it gives you the color orange, and you start following it now from the way it's started. You click wherever you see a calcification, you click, and here there's this table. As you are clicking, the number of lesions is going to be changing, and it's going to be giving you a volume of those lesions altogether. And when you click on your report, you actually get the number of lesions. For example, this patient that I was using, the number of lesions in the right coronary artery was 6. You can see the mean and standard units were given that. Each of them, the left main coronary artery, the left anterior, each of them, the number, as long as you click, it records automatically. So the aorta and then the other small branches that you may see are not included in the total calcium that you get at the bottom. Only the other main, the RCA, LM, LAD, and the left circumflex. So if you can see, when you just look even at these two images, this is why I was insisting on anatomy. If you wrongfully click and you think this is if you see my pointer, this vessel here that is branching, if you don't know that it's the RCA and you click it at the left main, or if the LAD, you click it at the left circumflex artery. So you end up giving wrong data here. And then wrong interventions could be taken. It's always important to know that you have your anatomy at the tip of the hands. Then below this, you have a reference point depending on gender and age. So if your patient, for example, is a woman who is age 53 years, so you go down here at the right bottom where there's women, you see that for the age group that you are looking at, she's 53 years, so she's falling under the second row. And then you check for the sensitivity and the specificity of that examination, because it changes according to the age group and also according to the gender. And you go now to assess the actual coronary arteries. So for this one, you go back to your volumes from the images that you obtained, and you use now the 75% volume. There are various volumes that are going to come after you scan. So for the coronary artery assessment, you're going to use the 75% volume, and you now start assessing the coronary arteries themselves, the lumen. Is there any reduction in the size? Is there any anomaly? Are they originating from where they're supposed to, and all that? So, for example, this artery that you're seeing here, on my right, there are 3 boxes, and they are not very clear, and I'm sorry about that. I failed to get a clearer picture. So the right side is just for you as a technician as a technologist, to make sure that your cursor is right in the middle of the vessel. Otherwise, the image on your top left may appear as if there is stenosis when there is no stenosis actually. Maybe the tracer on the other side is just not right in the middle of the paper. So you have to make sure that your tracer is right in the middle for both these three boxes on your right. And then now you start assessing the vessel from where it started. Remember, you are checking it all the way up to where it's ending. And then if you see any reduction in size, any increase in size, you document this. But just make sure that after you are done assessing, you are going to now save it, which is what you see on your left bottom. You save the whole vessel, make sure you include everything, and then now you send to PACS for the radiologist. As the radiologist is the one that does the reporting. So if you are done with the LAD, for example, if this is the LAD, you go to the next one, you do the same thing, make sure you check the whole lumen, and then you save just like that, check the whole lumen, you save till you've saved and labeled all the coronary arteries that were able to be visualized during the examination. And now you can go to your cardiac function. So remember, for the information you wanted to bring out is calcium score. You want to assess the coronary arteries themselves, and then you're also interested in checking cardiac function. So this is only possible, as I mentioned already, under retrospective gating. If you used prospective, you can't check for cardiac function. So now if you use retrospective, you can go ahead and do your cardiac function. Evaluation of MPR images in combination with the routine use of cardiac imaging planes now will allow you for comprehensive evaluation of both the cardiac anatomy and the function. Let's get right to the images just to drive the point home. So if you see these images, image is from Google. This is a horizontal long axis. These are just MPR images. So the horizontal long axis, it's going to show you actually all the chambers of the heart. You'll be able to see the left ventricle, the left atrium, the right ventricle, and the right atrium. And then you can already see if it's the left ventricle, which is this one, the big black star here. You can already visually see the wall around it that is going like that. So if there's any thickening, sometimes before you even do anything much, you can already pick out that the wall is thickened. Maybe it may just be the lateral wall, it may be the IBS, but you can already pick out certain things. The other thing that you can check out for is the size of the chamber itself. As you can see on this image, we're able to calculate the left atrium area. This you can do for even the left ventricle. The three-chamber view will allow us to see the papillary muscles both in two planes. If you can see here, these are the muscles here. These are the muscles here. They're actually pointed with the white arrows. If there's any pathology here, you are able to check. The vertical long axis allows you to check for the left ventricle, the left atrium. You're able to see them right here. Again, you can see the thickness of the wall, the size of the chamber, and the size of this chamber as well. This one, the short axis, which is very, very important. You'll see when you go to the next slide. So this one, you can actually see here, this is the size of the chamber in short axis. This is the size of your wall thickness of the left ventricle. And you can still see the right ventricle right here. So for function, remember, for you to assess for function, you need to be able to bring out things like ejection fraction. So now this is where you are going to utilize the fact that retrospective gating allows you to produce multiple segments of the heart itself. So you're going to go to your left ventricle. Now, this is your left ventricle, the black dot. Specifically the left ventricle, you are going to start getting multiple segments from the apex of the heart right to the mitral valve. But remember, you don't want to include the mitral valve themselves for function. You don't want to include also the apex of the heart where there's no chamber. So you get multiple segments, and then you are going to select on the machine. There's the part that shows inner wall and outer wall. So you're going to outline the inner part of the wall of each of the slices that you get. So let's start from the bottom on my right. This one, you don't want to use this because you can't really see a proper chamber here. But here you can see a proper chamber. So you outline it, the inner part, and the outer part, you outline the wall. Same here, the inner part you outline, and the outer part you outline. Just like that, till you reach the superior aspect, right before you reach the valves. Remember not to use the slice that has valves in it, because it will give you wrong, it's going to affect your results and give you wrong data. So the sagittal MPR is going to show you the inferior vena cava. It's going to show you these different structures as well, which just really allows you to assess for if there's any morphological pathologies. You're able to pick them. You're able to pick them out. This one will allow you to assess for your. It will allow you to assess for your left atrium, as well as the aortic valves themselves, which have 3 cusps, which you can see here. If there's any calcification to these, you'll be able to pick it out. The left atrium is here. Also, if there's any masses, any thrombi or thrombus, you can just pick it up. And then when you're done now, you click on your report and you get your report. So for this patient, the ejection fraction is given there, the end diastolic volume, the end systolic volume. You get your cardiac output. If you had any myocardial masses, you're also able to approximate how much the myocardial mass weighs. And then remember, you also scan the whole chest when you're done. So now you also come and make sure you assess the whole chest. Make sure then that you send to the radiologist after you are done to make sure that everything is fine. So when you get your report, when you get also the report for the calcium score, these things are sent to the radiologist. However, the radiologist system is much more complex, and he or she is able to get more information, and they're able to do and obtain more data than the workstation that the radiographer has. But basically, you are still able to get on your workstation all this information here. So what are the advantages of CCTA? So CCTA, we've seen already that not only will it provide you with more information about the morphology of the heart, the coronary arteries, the valves themselves, the pericardium, the cardiac walls, it's also going to provide with you function. And then calcium score also is obtained. And then this gives you actually you can estimate the future risk of it can estimate the future risk of coronary artery disease, even if the patient doesn't have any vessels that are occluded completely, you can still say, estimate to say in the next 10 years, if this person doesn't change their lifestyle, what is the likelihood that they may suffer from this? So it just really gives you all that information. It's low risk, it's non-invasive. It has a lower radiation as compared to cardiac catheterization, and it is accurately able to detect a great stenosis or if there's any narrowing in the lumen of the vessel. Just like any other examination, other modalities in the radiology department, the cardiac CT angiography also has a limitation in that first it uses radiation, ionizing radiation. So we know that our pregnant women may not be able to go through this. Also, children, this makes it not become the first option if you want to assess for any anomalies, let's say congenital anomalies in a child. And the radiologist will mostly recommend that the doctor actually considers other modalities. Also, morbidly obese patients, because they are contraindicated, this is their limitation. Patients with irregular heart rates. And then for abnormal CTA findings, you find that if there is a blockage or narrowing, the cardiologist will still, or the radiologist or the specialist, that is whoever is supposed to, whoever is in charge of the patient, may actually decide that they still go ahead and still do cardiac catheterization. So thereby now you are subjecting the patient to 2 examinations. So certain studies have actually argued to say, why not just go straight to cardiac catheterization? And because in the end, if you know the patient has a high risk for coronary artery disease, most likely they may have to go cardiac catheterization anyway. But it still remains a good alternative, especially in those who have a lower risk of 50%, probability of 50% or less for coronary artery disease. And then looking at children themselves, I mentioned a little bit about children in the previous slides. Mostly children do not undergo cardiac CT angiography. Mostly why? Because of some major technical difficulties that are associated with children. They have a fast heart rate, and then their heart is still very small, so their structures are very small and to visualize, and they are also unable to hold their breath, which greatly affects the temporal resolution. So even if you go ahead and do this, most of the times you find that the diagnostic value of the images is not so good and doesn't provide much information. Thereby, you're just irritating the child. And then, however, certain studies have said that maybe there's room to study this. So if, for example, some optimal cardiac intervals are developed, if you can still get that high heart rate, and then optimize it to cardiac intervals, maybe something can be worked out. But currently, children are not usually sent to do cardiac CT angiography. So I did a bit of comparison between the traditional coronary angiography, which involves catheterization, and the cardiac CT angiography. So you see that the cardiac CTA is non-invasive because it doesn't require catheterization. So for patients that cannot tolerate catheterization, it means they are able to undergo this examination without much difficulty as compared to the traditional coronary angiography. And then when you also look at the sensitivity, especially when assessing stents, that are less than 3 millimeters. CCTA is also very sensitive and actually has a higher sensitivity than coronary angiography. However, it's only diagnostic, but when you look at the traditional coronary angiography, it will also sometimes involve therapeutic factors, because the person doing it can just right there when there's a pathology, they can just right there perform corrective measures. The coronary angiography also has a very good resolution. If you can see the image on my right here, how the vessels are appearing, the visualization of the vessels is excellent. You can even see the tiny, tiny small vessels there. While on the other hand, the CCTA may not show the coronary arteries all the way up to the apex, which is one big disadvantage of the coronary artery, of the cardiac CT angiography, is that it may not show the small vessels, and even the vessels that it shows, it may not show them all the way up to where they end. So if there's any reduction in size, or if there's any stenosis in the distal part of the coronary artery, this could be missed. So you can look at a few cases just to push the points home from the previous slides that were just from checking. So if you see the image on my left, the LAD right there is just, you can see it, you can't see any increase in density, you can't see any hypertension, any sort of hypertension in the coronary artery. But on my right, you see some increase in density in the vessel, as well as a little bit in the left circumflex artery. So this is calcifications. You can follow the vessel all the way up to where it ends. This image also shows a vessel with calcifications right here. They are kind of scattered throughout the vessel all the way up to where it's ending. Then this image is showing a congenital anomaly where the left anterior descending artery is arising from the main pulmonary artery instead of it arising from the ascending aorta. This one will show, is showing an anomaly again, where the right coronary artery, you can see where it's, instead of it arising from here, the right side of the ascending aorta, you see it arising from the left side of the ascending aorta. In this, in the next case, this one, you can see this vessel, the right common carotid artery is coming down here. If you are able to follow it nicely, there's no reduction in size anywhere. There's no disruption of the contrast. You can even see some of the branches that come off it. And then, but the next image is not very clear, but you can see the actual size of the vessel is all the way up to here. But you see contrast is only almost at this focal area, you only see contrast, only about 75% of the vessel. So this shows that there is something here. You can see that there's plaque that is seen at this, on this part of the coronary artery wall. In this image here, you see stenosis. There are parts of the artery. You can only see a little bit of the contrast going in like that, but you don't see any contrast on the sides of the vessel here. This image will show dilatation in the coronary artery. So if you look at the size here, the size here, size here, size here, and size here, you see that it's different. There's a lot of dilatation in multiple areas, which involves about 50% of the total length of the vessel. So what are the key points in our take home? Patient preparation cannot be overemphasized in order to make sure that your temporal resolution is optimum, your contrast resolution is optimum, your spatial resolution is optimum. You need to communicate to the patient, to the doctor, and to the nurse that is actually in charge of the patient. And the patient has to be calm. If the patient is scared, take your time to make sure that the patient calms down before you go ahead and do the examination. It's even better if it's not an emergency. It's even better to say we can't go ahead with the examination at this point and to wait till the patient calms down than to go ahead and then you get poorly diagnostic images. So just sufficient communication between you as the technologist, the doctor, the nurses, and the patient as well. And you should continuously assure the patient throughout the examination to make sure that the patient does not panic. So there still remains room for more utilization of cardiac CT angiography, but right now, very few centers utilize this. Even for us, though we do cardiac CT angiography, we rarely do this. This year, we haven't yet gotten a patient for this. So even with most doctors, they will not really send, they don't usually send the patient to come and do cardiac CT angiography. So it's not so utilized, but there's room for more utilization, as we have seen that it can provide all this information. It can also provide function, it can provide morphology, and it gives very good, it can grade stenosis and grafts, and it's got very, very accurate grading when it comes to stents and grafts. So there's still room for it to be more utilized in the department. So this marks the end of my presentation. And if there are any corrections, additions, questions, or anything else, they are now welcome.